Good morning, everybody, and welcome to Pediatric Grand Rounds, now on WebEx. I'm Suzanne Mazer. I'm the director of CME here at Seattle Children's. So thanks so much for being here. This morning, our speaker is Dr. Nivian Blondette, who comes to us after residency in pediatrics at University of Texas, Houston, fellowship in pediatric gastroenterology, University of Texas, Southwestern Dallas, and then another fellowship in pediatric transplant hepatology here at University of Washington in Seattle. She joined our staff in 2017 in the Division of Gastroenterology at Seattle Children's Hospital, and her clinical interests are, among other things, non-alcoholic fatty liver disease, portal hypertension, acute liver failure, and liver transplantation. We're really excited she could be here virtually here with us today. So welcome, Dr. Blondette.
Thank you so much for having me. Today, I'm going to be talking about neonatal cholestasis. And I just called it more than yellow eyes and pale stools because I think that's something that it's innate in us from even our residency training in general pediatrics, that we're always looking for those pale stools. But there's so many other conditions that can give you cholestasis that not necessarily have pale stools, or even with the classic biliary atresia, which is the one that we look for the pale stools, it might not happen until later on the disease. So my goal today is to try to give you pearls about different cholestatic diseases that you may see in the common pediatric world and also in other subspecialties. I'm going to give shout outs to endo, cardiology, a lot of other services. So hopefully it's very interactive, and please, please, please ask me questions if you have any. I have nothing to disclose, and we are going to go over these different goals. We're going to define neonatal cholestasis, but especially we're going to define the differences between what physiologic jaundice and what a more pathologic jaundice in the newborn is, or that cholestasis. We're going to review the differential diagnosis. I'm going to explain to you how we work these babies up, and then we're going to go over some points of management, mostly focused on nutrition. Okay, so if you guys have been part of any of my presentations, you may know that I like to use Paul everywhere because I'm going to ask questions. Direct and conjugated bilirubin are exactly the same and thus are interchangeable values. You're going to text A if you think that's true, or B if you think that's false. Direct and conjugated bilirubin are the same. If you didn't realize that there were different types of bilirubin, then you can also text A. Okay. All right. I'm going to close this one. Now, this is going to be a poop test. Now, the next, I think it's like 5 questions. These are real pictures that I get. These are like my friends' kids' poops, most of them. And I get this constantly. I bet all the other GI doctors do too. Is lots of pictures of, is this normal? Is this abnormal? What do you think? So these are not pictures that I got from the internet. Again, they're pictures that I receive throughout, and I actually asked permission to one of the dads because he had a really nice collection. Okay, normal. Nobody thinks that it's abnormal. Okay, that mucus is okay. Perfect. All right, next set of poops. Normal or abnormal? Again, these are real pictures that I've gotten, and I love how my friend, she compared it to the carpet, so that to make a point that it looked a little bit pale. Normal or abnormal? Perfect. 80-20. Next one. Normal or abnormal? Text A if normal, B if abnormal. This is the first one of the 3 from our patient. Okay. I'm going to move on. Okay. Normal or abnormal? Again, there's like, this is not a, even though it's a little bit of a test, it's really just for me to know. I don't know who's answering. Perfect. You know, I like that it's like 60-40 because this is a hard color that most people struggle with. So last, normal or abnormal? Yeah, 50-50 initially. That's the good. right, perfect. Just so that you guys know, probably I would have considered the last two abnormal, and these are all stools from the same patient that ended up having biliary atresia. So, what's neonatal jaundice? So, jaundice, that word is derived from the French word jaune, that just means yellow, and it pretty much means discoloration of your skin, your mucous membranes by the deposition of bilirubin. And it can be really subtle. So, this is actually one of our patients. Our parents are really good at taking pictures of their kids, and you can see a little bit of the discoloration on the eyes. Now, obviously, this is what we do every day, so I think we have very sensitive eyes for jaundice, but it can really be very subtle. I don't know if you guys know about the Kramer's Index. This actually has been around since 1969. So, and this actually, I went to medical school 2006 to 2010, and this is what they taught us in Puerto Rico as well. So you can see jaundice for about a level of 4 to 6 in your face, your eyes 8 to 10 in the upper body, and so forth. And by the time you can see it on your feet, on your hands, about 15 to 20. Now, it's a relatively okay method if you're not jaundiced or if you're very, very jaundiced. But if you're in the middle, you have dark skin, it's going to be relatively unreliable. Now, I know that you, depending on your skin color, right, it's going to be harder. But if you have, like, for example, Hispanics, Asians, people with a little bit of darker skin, if you press on their skin, actually, and I wish, again, we were in person and I would show you like on my own skin. If you press on your skin, you're going to truly like have your underlying kind of like tone. And in our kids that are jaundiced, you can tell right away after you press the skin if they have a little bit of a yellow kind of like tone to the skin. That's actually quite reliable. But obviously on the eyeballs is going to be the best way to assess because pretty much everybody has that area white, right? So again, very reliable if you either have deep jaundice in the extremes or you don't. Jaundice is super common, actually. So some authors estimate that even up to 80% of neonates born relatively term or late preterm have jaundice. 80% is a lot. So it means that probably, especially if you're a general pediatrician, again, 4 out of 5 kids that you see are going to have jaundice, which, again, is a lot. So what causes jaundice? So the most important thing is to learn a little bit about bilirubin. So how is bilirubin formed? So bilirubin is a byproduct of heme metabolism. So we all have bilirubin of some amount. Now, bilirubin gets bound to albumin, then gets delivered to my hepatocytes where it meets my friend EGT1A1, which is important in diseases, for example, Crigler-Najjar. You have absence of that. It's important too in breast milk jaundice. Some people suggest on Gilbert's as well. So this UGT is one of our friends of hepatologists. So after we have a conjugated bilirubin, it goes to your gallbladder and then into your intestine. Now, most of it you poop out. Some of it is going to be reabsorbed by the enterohepatic circulation, and then our nephrologists are going to help us get rid of some of that conjugated bilirubin, and then the unconjugated just keeps cycling around your body. And this happens all over. Now, obviously, if you have diseases, for example, that you're NPO or you have an obstruction, for example, if you're NPO, you're going to have flow of your gut, and you're going to have more of this reabsorption from your intestines. So you might have an elevated conjugated bilirubin. Obstruction, obviously, you're going to spill more conjugated bilirubin. So it's very important to know the pathway on how bilirubin gets rid of your body to know in which areas it can get accumulated. So going back a little bit to what benign neonatal jaundice is. So benign neonatal hyperbilirubinemia, in my mind, is a result of elevated unconjugated hyperbilirubinemia. It's pretty much normal and happens in every single newborn. And it's due to pretty much that the liver just still needs a little bit of time to be able to keep up with the breakdown of the blood that's happening from the transition into the in utero life to just the regular newborn. So it's a very common process, and that's why, again, as a general pediatrician, 80% of babies have bilirubin that's elevated. Peak total serum bilirubin is going to depend on a bunch of things, including diet, ethnicity, differences in hepatic uptake. So you're going to have a lot of variability. And this is where you refer to that nomogram, the Butani nomogram, to determine, oh, is this like a worrisome level that I need to do something about? But again, this is just based on unconjugated hyperbilirubinemia. Now, jaundice usually resolves by 3 weeks in over half of your newborns, but by week 3 and 4, still about 20% of them are still going to be jaundice. So still a significant component. So again, 1 out of 5 of your newborns are still going to be jaundice a little bit later. And that brings me to one of the most important points, is that not all jaundice is the same. Okay, again, most of your newborn kids are going to be completely normal with a physiologic indirect jaundice, but you're still going to have a couple of those that are not going to be just normal, and we need to identify when to worry. To me, the timing at the 2-week-old visit is the perfect time. So if you have a newborn that's still persistently jaundiced at that 2 weeks of life, you need to pay attention. You shouldn't just say, oh, this is, I mean, it is probably physiologic jaundice, but you should follow it and not just tell the family, oh, this is going to go away, it's going to be fine. Now, NASPGHAN is the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and they have very specific guidelines of what to do with this newborn. So if they're jaundiced after 2 weeks of age, you should get, if you hadn't done before, a total and a direct bilirubin. So you need to fractionate that bilirubin. So again, if you have a newborn that's jaundiced at the 2-week mark, think about getting that total and direct bilirubin, not just the total, just fractionated. Now, previous guidelines back in 2004 had said, you know, if it's a 2-week well-child check and the newborn looks good, there's no other findings on exam that would be concerning, like lethargy, hepatosplenomegaly, abnormal facies, anything else, you can wait 1 more week and then obtain the fractionated bilirubin then. So we still, some of us still practice that, but my message to you again, in that 2-3 week period, if your infant is still jaundiced, you need to obtain a fractionated bilirubin. So when do we worry about when is the bilirubin too high? So there's actually different ways to test for bilirubin, and I'm going to get to that in a second. So just to keep it simple for you guys. So at the 2-3 week mark, if you have a conjugated or direct bilirubin above 1, or your direct component is over 20% of the total, we worry. Again, conjugated direct over 1, or if you have a direct component over 20, probably that's reflective of cholestasis, especially at that 2-3 week mark. So either you call us or you follow it up, but don't just ignore it. Now, going a little bit to conjugated and direct. So they are actually not the same. And I picked this. This is not my table. I didn't create it. There's a little bit of typos, I know, but this is the best one that I could find that explains the relationship between direct and conjugated bilirubin. So bear with me because this is really, really important. This is the Vitros method. This is how we actually test it here at Seattle Children's. There's different methods, but this one can test total bilirubin, as well as it can give you a specific measurement of indirect or unconjugated bilirubinemia. Now, this author labels it as BU, which I'm guessing is unconjugated bili. So how they calculate the direct is going to be your total minus the unconjugated, okay? Now, this method can also calculate a conjugated bilirubin. So you're going to have a BU and a BC, and if you sum these two, they don't add up to the total bilirubin. You see, unconjugated and conjugated, they're not the same. And this is because of my friend, the delta bilirubin, which is also calculated indirectly. So what is delta bilirubin? So delta bilirubin is a component of bilirubin that's bound to albumin. So again, my direct bilirubin and my conjugated are not exactly the same. Be very, very mindful of that. Why do I mention that? Because your conjugated bilirubin is going to have a way shorter life than your delta or your direct bilirubin for that matter. So, for example, if I have a kid that comes with an episode of jaundice or they have biliary atresia, we follow, we do a Kasai, and we're following their bilirubins, and in the hospital, the conjugated goes to 0. And we're super happy we discharge the baby. And then they follow with their pediatrician, and a pediatrician checks a direct bilirubin. It might be higher because, again, you're going to have some bilirubin that's bound to albumin, so they're going to be discrepant. Actually, and I don't have a good way to calculate it. I just follow either apples to apples or oranges to oranges, and I just follow those trends. The dad that took the pictures, he actually created an Excel spreadsheet, and then he can tell me specifically like what the conjugated bilirubin is to the direct bilirubin using an albumin. Like this guy is, he loves data. So I was like, send me the pictures of the poop. So again, pearl from here, direct and conjugated are not the same, trend one or the other, but the conjugated bilirubin has a way shorter life half-life because of the delta bilirubin being bound to albumin. So cholestatic jaundice is relatively rare, but it can cause serious issues. It only occurs in about 1 to 2,500 live births, so some pediatricians might go throughout their careers without seeing a cholestatic baby. But it's very, very important for you to be able to recognize them and know that it can lead to serious pathology. Newborns are particularly prone to cholestasis, and it can be due to hepatocellular injury, obstruction, mechanisms that are faulty that you cannot create and excrete the bilirubin appropriately. So these kids need to be evaluated. Now, the differential diagnosis for neonatal cholestasis is very broad, and I only picked several one of these that I think are a little bit, not that they're more common, but we see them frequently with, especially with other services. So I wanted to kind of like give you pearls about some of this so that you can remember and think about them in your day-to-day life. Now, this is an old slide from 2004, and while it doesn't have the specific percentages, you can still see that biliary atresia has a big component on the etiology of cholestasis. Now, there's this group that they call, quote, neonatal hepatitis, which tend to be kind of like the unknown etiology. You did a biopsy and it was not specific. Some of them resolved, some of them kind of like evolve and continue needing further care and liver transplant. But fortunately, new advances, including genetic testing, has allowed for that gap to be bridged. And now idiopathic causes are only about 10, maybe 15%. Biliary atresia still remain the number one, but you can see that the diagnostic pool has expanded. This is a study from Germany, and the numbers are small, but this is actually quite reflective of what we're seeing day to day. If you guys are ready for more, I'm going to start talking about different causes of cholestasis. This is actually one of our biliary atresia kids. Again, the mom is great at taking pictures. And I thought it was very Cinco de Mayo appropriate too. So biliary atresia. So biliary atresia, the name, the typical name that it's more official, it's actually extrahepatic biliary atresia. So most people think that biliary atresia is a disease that just affects your bile duct, your extrahepatic, your gallbladder, like you're not born with it or it didn't develop appropriately, but it's actually a progressive disease. And that's very, very important because that's why we see the pattern of transitioning into pigmented stools initially into maybe then alcoholic stools later. It occurs in 6,000 to 18,000 babies without well-documented familial cases. Now, I put an asterisk there because recently we had a baby that got diagnosed with biliary atresia that the brother had biliary atresia as well and got a transplant. And Dr. Hersland said that that was the first child in his career that he had seen with familial biliary atresia. And the babies also had, for example, horseshoe kidney. So had like a couple of other things that may be leading to a genetic diagnosis. But we even have, for example, twins that one of the twins has biliary atresia and the other one doesn't have any issues. So it's very sporadic, and in general, again, not associated familial cases. And that the patient on the previous picture had biliary atresia too. In about 10% of the cases, it may be associated with other congenital malformations. One of the things that we see is splenic malformation. They can have asplenia, polysplenia. This little girl had asplenia and situs inversus. So you can have different things. And why I mention this is because a lot of the times when a general pediatrician is thinking about biliary atresia or cholestasis, they get a limited abdominal ultrasound to the right upper quadrant. And a lot of the times it's really, really helpful to get a full abdominal ultrasound, because then I can see the spleen. If it's big, then I'm worried about other things that I'm going to talk about in a second. But again, a full abdominal ultrasound in some of these babies is really, really helpful. Like I said, this is a progressive disease. So infants typically are perfect at birth. They look happy, they're growing, they're feeding well, they get discharged. Actually, they did a study that in Utah, I believe, they actually standard was to test total and direct bilirubin on jaundice babies before they left the hospital, not just like a total one, but actually fractionated. And most, if not all, babies showed already a direct hyperbilirubinemia at birth. So even though, again, the clinical signs that you see on exam or on history may develop a little bit later, most importantly that I want you to remember is that this is a progressive disease. So they're going to look healthy. They're going to look really, really good at that two-week-old well child check. That doesn't mean that they don't have biliary atresia and that they're going to get in trouble soon. Workup typically includes imaging and histologic evaluation. I'm going to go over those things later, so I'm just going to keep going. When we suspect biliary atresia, they go to the OR. So our surgeons do an intraoperative cholangiogram, and that's the way to diagnose actually biliary atresia. They're not going to see the bilirubin excreted into the intestine. And then at that same time, they usually take a biopsy and then do the enterostomy. So they grab the bowel and connect it into the liver. And then this is going to be your roux. And usually this is one of the surgeries that the outcome is very, very related to surgical expertise as well as timing. So here at Seattle Children's, we usually have one of our transplant surgeons, actually is the one that does our Kasai's, Dr. Healy. I actually like that because then, these kids may continue progressing, so then he already knows the family in case they do need to be transplanted or, I guess, evaluated for liver transplant. So again, one of the only few surgeries that outcomes is truly, truly associated to surgical expertise and timing. Now, even after you do a Kasai and you say that it went great and everything is looking good, again, this can continue to be a progressive disease. So a lot of our patients are going to develop fibrosis, portal hypertension, and cirrhosis. So just clearance of bilirubin, which we usually say after 3 months of the Kasai, if you clear your bilirubin, you're good. Most of the patients are still going to have sequelae of chronic liver disease. And because of that, biliary atresia continues to be the most common reason for children to need a liver transplant. About 50% of kids who have biliary atresia will require transplant within the first 2 years of life. That number is way higher if you did not clear your cholestasis after your Kasai. And an overall incidence of liver transplant of about 80% in childhood. So again, if your Kasai went well and you did really good, that's great, but that doesn't exclude you may be needing a liver transplant in the future. So how I actually talk to my families now about biliary atresia, I actually mentioned that liver transplant is part of the management of the disease. It's not like Hail Mary, kind of like worst case scenario. No, we're great at liver transplant, and that is part of the management of our kids with biliary atresia. And this little baby girl was actually a late diagnosis biliary atresia and got her transplant and is doing fantastic. Alagille syndrome, I know this kid, also known as arteriohepatic dysplasia. It's an inherited disease that is inherited as an autosomal dominant way. most of the kids have a mutation in the JAK1 gene, but there's also Notch2. There's also kids that don't have a clear established genetic diagnosis of Alagille, but they have the faces and they have the other features that I'm going to go in a second. So we call them like, Alagille phenotype or Alagille-like until we can prove genetically that they are. So we treat them as such. One of the most important things about Alagille is that I don't have two kids with Alagilles that are the same. Even within the families, they all act very differently, and their disease progression is very variable, mostly related to the amount of organs involved. Now, these Alagille kids, they look similar. They have these triangular faces, this kind of like broad forehead, but sometimes it's really, really hard to tell right away that they have Alagille. When I see a kid that I think has Alagille, I look at the mom, I look at the dad, and they usually don't look like the mom or the dad. Sometimes they do, and then we start like asking about family history, and some parents like don't like didn't know they had Alagille until we later diagnosed the baby, and then they get genetic testing, and we have a case, a baby that's now probably 8, 9 months old, and family history of lots of death related to liver disease of unknown etiology, nobody knew. And then we saw the baby, and the baby got diagnosed with Alagille, so then the mom got tested, and everybody else got tested, and now the family carries that diagnosis. Kids present with a bunch of things. So shout out to cardiology. We share patients with them. They can have butterfly vertebrae. They have a propensity for fractures. Shout out to nephrology as well. They can have a bunch of different kidney disease. Importantly, they're at risk of stroke from intracranial bleeding, so sometimes we do screen them for moya before putting them on a big surgery like transplant or cardiac surgery. They can have lots of problems with itching and develop these xanthomas that are very debilitating, and actually xanthomas and itching can be an indication for liver transplant as it impedes or interferes with your quality of life. And there's even reports of adults, patients that have killed themselves because the itching is so difficult to control, so that's why it can be an indication for liver transplant. But this guy, look at him, he looks so yellow before he got transplanted. These Alagille kids, they tend to be angry, and like they're always kind of like serious and very ungrateful. But look, just a couple of days after transplant, he looks fantastic, and he's done quite well. Alpha-1 antitrypsin deficiency. So it is actually the most common cause of inherited neonatal cholestasis. It's relatively common, occurring in 1,600 to 2,000 live births, but very few of them actually have clinically significant liver disease, which is related to the ZZ phenotype. So actually how we test for alpha-1 antitrypsin is by the phenotype. A lot of people send the levels, but what we're really, really looking is into the phenotype, because you can have relatively low levels with other of the phenotypes, but the clinically significant liver disease that we worry about is related to the ZC phenotypes. Once you diagnose a child with having alpha-1 antitrypsin, actually guidelines recommend for you to screen siblings, the parents, because they can be carriers and they don't know that they have liver disease. Why is that important? Because alpha-1 antitrypsin can lead to lung disease, so you want to give them lifelong advanced precautions in terms of other things that they might develop while they might be completely asymptomatic. So this little one got transplanted when he was 6 months old for alpha-1 antitrypsin, and he's doing quite well, as you can see from the picture. I love him. So again, it can lead to both liver and lung disease, so shout out to pulmonology. We tell them that they cannot smoke lifelong, no vaping, no cigarette smoking. If they're going to go to like barbecues and, stuff like that, we tell them, oh, keep an eye on where the smoke is blowing. We want you to eat the s'mores and whatnot, but you really have to keep an eye and stay away from the smoke. And this is going to be a lifelong thing that they're going to have to watch for. In regards to liver disease, it's again supportive. Most of them, even if they have neonatal cholestasis, resolve. Some of them will have chronically elevated liver enzymes. They can develop issues with portal hypertension. So again, very, very variable course. But they can do really, really well after transplant, like this guy. Another set of genetic diseases, and again, I'm just going to focus on the things that I want you to remember from a general pediatrics or kind of like a subspecialty. So there's this progressive familial intrahepatic cholestasis. So again, they're genetic, they run in families, they're progressive. They might not necessarily present with true neonatal cholestasis, but they happen. Why I want you to remember these diseases is because they have a very characteristic pattern of GGT. So PFIC1 and 2 are going to be one of the pretty much only diseases that have a low GGT in the setting of cholestasis. There's other diseases, but these are the ones that you might commonly see um, um, in the subspecialty or the general pediatric. Now, it's very important to know that normal newborn GGTs is going to be really high. But again, we're worried about the setting of cholestasis. So on normal GGT, I'm thinking PFIC. A little bit of other congenital anomalies. So this is more of a shout out for surgery, I guess. So choledochal cyst is something that they always teach us in medical school as a possible cause of neonatal cholestasis. Now, I learned this classic triad: abdominal pain, right upper quadrant mass, and jaundice. I have never seen a kid that presents with those three. Actually, I have never, ever palpated a choledochal cyst, even though I have a lot of patients that have choledochal cysts. Most of them present with either just jaundice, and then because you're getting an abdominal ultrasound to evaluate for biliary atresia and this, then you pick it up. And they're still most commonly seen in pediatric patients, but in adults, they usually present with right upper quadrant pain and maybe like a cholangitic process. But only a third of the patients are reported to really present with this triad. So most of the times, again, we see them because they present with jaundice and somebody got an ultrasound. Choledochal cyst can rupture. Actually, I have a patient that's how she presented. She presented with ascites and cholestasis. And then we did a tap, and it was pure yellow. And on imaging, they saw the choledochal cyst that had ruptured. So they can rupture. It's relatively rare, but it happens. There are several types of choledochal cysts. Why I mention this is because type 5, for example, has intra and extrahepatic biliary dilation and can be associated with renal disease, for example. So this is part of our ductal plate malformations. So we see them associated with polycystic kidney disease. So again, shout out to nephrology. Endo. So lots of kids that have issues with their hormones can have cholestasis. And why is that? So these hormones are known to cause regulation of how you excrete bilirubin from your body. Thyroid is by far the one that has been associated the most, but panhypopit is a very common, not common, well-known cause of jaundice. And, you know, there are some of these kids that we get consulted on, and they're on the endocrinology service or even in the NICU, and we say, oh, it's one of these endo kids. Like, we haven't been able to determine what the true endocrinology abnormality, but they're going to be hypoglycemic on diazoxide, and they're cholestatic. And I'm like, oh, it's just one of these kids. So once you fix the metabolic abnormalities, they're going to get better. Now, these are kids that can have other findings on exam. And why I mention this is because, for example, a couple of years ago, probably like 2 years ago, I had a baby that came for cholestasis, urgent evaluation, and then the baby had nystagmus on exam. And instead of just doing like a quick evaluation, it was a 4-week-old, for biliary atresia, for example, what we usually do, we actually urgently checked glucoses and did like an endo. Ophthalmology actually was able to see the kid right away, and he was diagnosed with the septo-optic dysplasia and panhypopit. So again, keys on exam, on history that might point to diseases that are cholestatic but are not necessarily biliary atresia. In general, too, these kids can have relatively normal GGT as part of this endocrinopathy. So another one of the sets that they can be cholestatic with a normal GGT. So shout out to endo. Now, NICU, if you're on the line, parenteral nutrition-associated liver disease. You can see it as early as 2 weeks of life. So this is something that can happen right away. We see it all the time. It's actually more common nowadays obviously in the NICU population because they're more preemie. Now, the good thing is that we're getting way better at managing TPN. So we know that both lipid restriction actually improves cholestasis, but also dextrose. So be very, very mindful about giving TPN to these kids and trying to get them to the growth chart and getting them to gain calories because even again, 2 weeks of parenteral nutrition can cause cholestasis. The overall incidence has decreased since we have fish oil based lipid emulsions. And I don't know if you guys know about SMOF and omega vents. So I'm just going to mention them briefly. So standard lipid is based on soy oil. And that led to, again, a lot of cholestasis and fibrosis because it has pro-inflammatory omega-6 fatty acids. Now, they were like, okay, so omega-6 is pro-inflammatory, so let's create something that's based on fish because it has omega-3, the trifecta. That's how I remember. It's good. So they created omega-ven. And then they saw that the babies were less cholestatic. You could actually reverse a lot of the cholestatic disease and fibrosis. But unfortunately, it led to a lot of essential fatty acid deficiency. So they created the best thing that we have right now in terms of intralipid, which is MUF. It's a combination of soy, medium chain MCT oil, olive oil, and fish. So it's way more balanced than your regular omega-ven, for example. So this is the thing that we're using more and more nowadays. We still standard use IL, especially if you're going to be on short-term TPN. Why we don't put everybody on SMUF, for example, there's not a lot of data on compatibility. So these are going to be a lot of kids that you're like, oh my God, like it's not compatible with their medications and whatnot, but it's a great option. Usually results within 4 to 6 months, but it can progress to liver disease, and we have actually transplanted kids, as you may know, for PN-related liver disease. Another shout out to NICU, GALD, previously known as neonatal hemochromatosis, is a disease that usually starts in utero. So it's an autoimmune disease, and then by the time the babies are born, they're usually quite sick. Now, the thing that I want you guys to remember from GALD, again, they tend to look sick. They can have kidney involvement as well. They have history of oligohydramnios in utero. They can have high drops, maternal history of fetal demise. But when they're born, they have a marked coagulopathy with normal transaminases. Again, marked coagulopathy with normal, relatively normal, 40, 50. And then you have an INR of 4. And then you have hypoglycemia. So these are kids that I always tell the fellows, if you have a coagulopathic kid with normal liver enzymes, you have to think about GALD. Treatment is IVIG and exchange transfusion. There's not a good, quick way to diagnose these kids right away. So if you're thinking about it and it's not like anything else that you're going to harm them with doing IVIG and exchange transfusion, then just go for it. Another shout out to NICU because they tend to see these kids that are sicker. Metabolic liver disease can present as cholestasis. I'm only going to focus on these two. Tyrosinemia, because on the boards they still love asking about the urine succinyl acetone as a way of testing them. And then galactosemia because of the E. coli sepsis. So again, board question, you put them on soy diet, avoid lactose, but those main two because of these two pearls in terms of general pediatrics. Torch infections can cause cholestasis. We recently had a baby that had CMV hepatitis, so shout out to ID for helping us manage him. But they can also have things that can point you to torches above other cholestatic diseases. History of maternal infection, kid with splenomegaly can be from tortious infection. So again, a couple of different things, your cataracts, chorioretinitis, and whatnot, that might point you into a little bit more of a viral etiology. Bacterial, we always need to remember, E. coli, especially urinary tract infections, can cause cholestasis. So bacterial infection, even mild, can still be as part of your differential for cholestasis. And last but not least, and this is how I'm going to wrap up the differential, is what we call idiopathic neonatal cholestasis. These are the kids that we do a liver biopsy, and then they have giant cell hepatitis. they're not associated with anything else. We do all the workup for biliary atresia, for example. They have relatively normal ultrasounds. All the infectious workup is negative. Alpha-1 antitrypsin is normal, but then they still have this giant transformation. It's usually self-resolving, but we see it sometimes associated to autoimmune hemolytic liver disease. So shout out to hematology. Diagnostic approach. So in my mind, actually, when I see a cholestatic kid, the most important part is history and physical exam. So now that we're doing a lot of telemed, I get very, very nervous when I'm seeing these new consults for cholestatic babies. So actually, we have them come to the hospital because I need to see them. I need to see if they're having nystagmus. I need to see if they have hepatosplenomegaly. Are they floppy babies? Is there anything else on the exam on history that's going to point me to a very specific etiology that's going to help me guide how quickly I need to move? Obviously, biliary atresia is going to be the most important thing that I'm worried about. But if I identify other things on history and exam, then maybe I can actually move forward with other things, like, for example, an urgent referral to genetics or endo. Stool color, super important, which is why I put the pictures. Now, we suck at identifying which colors are normal. They did a study in England, and these were all pediatric professionals, and only a third of them were able to identify. I'm sorry, two-thirds of them were able to identify the stool correctly. So a third, it's still a lot because we are pediatric professionals. So imagine asking a parent to identify if it's normal or abnormal. And to be honest, like, I mean, these two are not horribly, like, so different. So I think we have a really hard time at identifying acolic stools. Again, the last two on my poll, I would have considered a colic. But there's a really nice app that actually pediatric gastroenterologists at Hopkins developed. It's called Poop and D. It's free, and the parents can just take pictures of the poops, and then the app will tell you, oh, is this concerning or not? You should seek further medical advice. So I think it's actually really good. Laboratory workup, again, fractionate that bilirubin. You have a jaundice kid, 2-3 weeks of age, need to get a total and a direct bilirubin. Newborn screen is pretty standard. Again, if you're thinking about other causes, hemolysis, CBC is going to be really helpful. Thinking about sepsis, your UA, have to get a comprehensive metabolic panel, get that GGT. Sorry for the typo on alkaline phosphatase. And then alpha-1 antitrypsin phenotype is something that guidelines recommend that you can send as a part of your initial workup from your general pediatrician's office. So this is a pretty standard profile that you can get right away and can help you guide, do I need to call hepatology urgently? Is this GGT normal? Is really the baby, if it's indirect hyperbilirubinemia, then I don't need to call hepatology because probably it's physiologic jaundice. Imaging. So ultrasonography, we use it mostly to rule out anatomic abnormalities like choledochal cyst and biliary atresia. It's not perfect. If you see the triangular cord sign that I'm horrible at looking at it on the ultrasounds, but if the radiologist is like, oh, I have a triangular cord, then definitely increases my suspicion for biliary atresia. Again, remember syndromic BA, so think about getting a full abdominal ultrasound. Those spleens, is there a spleen, is there not a spleen, is there situs? That's going to help me guide my management. HIDAS are very controversial. Full disclosure, I don't like them. I probably have only consciously ordered a HIDA maybe 2-3 times in my whole life because they're not very specific. Now, if you have excretion, then yay, it excreted into the bowel. But every year there's reports of kids that have biliary atresia that excrete into their bowels. So be mindful. Again, biliary atresia is progressive. So if it's not excretion, then you're like, okay, something is happening, but it might not necessarily be BA. It can be another hepatocellular disease. A little bit of extra imaging. For example, in GOLD, if you're going to try to get more information about should I treat this baby or not, you can get a T2-weighted MR because it's going to demonstrate iron deposition in your pancreas. Liver biopsy, to me, is gold standard in terms of evaluating a cholestatic baby that I cannot identify. Again, it's not an endocrinopathy. It's not anything else. And there's very typical patterns that we see. So we see, for example, in biliary atresia, bile duct proliferation. In Alagille, we see paucity of bile ducts. Alpha-1 antitrypsin, Dubin-Johnson, PFIC have very specific patterns that we see in the biopsy. But again, a lot of them will also have giant cell hepatitis that makes the diagnosis then a little bit confusing depending on the timing of the liver biopsy. The later that you do it, the more specific it's going to be. Now, one thing that we have been using a lot is the cholestasis panel. I'm not going to go into it a lot. I'm just going to showing you this because actually it tests for all these things. For example, UGT, we said that it's Crigler-Najjar, Gilbert's, for example. So it tests a lot of things. It's not perfect for alleles. For example, it's about 50% good for it because it doesn't pick some of the mutations, but it's actually good enough. And you can even send it as an adult, the cholestasis panel, if you have an older person that is jaundice and you don't know why. So in my mind, early diagnosis means early intervention. Management of cholestatic diseases is one, identify what's happening so you can fix it. Endo, give them supplements that they need. PN, limit the lipid or limit the fat. Infection, treat it. But at the end of the day, the main thing that we follow in our chronic liver disease is nutrition. It is so important that these kids grow. These are little alpha-1 antitrypsin baby celebrating his 1 year post-transplant with a nice little cake, so eating very well. There's a lot of reasons why our cholestatic kids on chronic liver disease don't gain weight. They have anorexia because of a lot of things. They actually have increased nutritional requirements. They're catabolic all the time. They can have nausea. They can have bacterial overgrowth, especially at the rumen that can cause diarrhea, abdominal pain. Portal hypertension can lead to congestion that then you cannot absorb nutrients. So a lot of reasons why they don't grow. But the one thing that I want you guys to remember, you need bilirubin in your gut to be able to absorb fat-soluble stuff, so fat and fat-soluble vitamins. So if you have a cholestatic patient that, for example, biliary atresia or any of the diseases that you're not getting the bilirubin into your gut, you're not going to be able to create micelles to absorb fat. So fat-soluble vitamin deficiency is something that we see very commonly. If you're going to replace, for example, vitamin K, that leads to INR and other coagulation factors, and I'm not going to go into them, but what I want you to remember is vitamin K, in the setting of cholestasis, you have to think about replacing it IV or IM and not only enterally because it's not going to be good enough. They need loads and loads of those vitamins to be able to mount a good response. MCTs are actually the one type of fat that does not need that micelle to be formed to be absorbed. So that's why we supplement a lot of our kids with MCT oil and not necessarily other oils. Now, our go-to formulas are progesterone and alimentum because they have a high amount of MCT. So again, MCT oil, supplement that way. You need extra calories they're not eating. You're trying to get them big. That's a good way to supplement. And the reason why we pick progesterone or alimentum is because of the MCT, not because they're broken down. It's because of the oil that they have. Some of our kids end up getting PN if we cannot get them to grow because, again, they don't want to eat. They don't tolerate formula by NG. So lots of reasons. And if you give PN, parenteral nutrition, the right way, you can get them actually to improve their liver disease with good nutrition. And we have seen that. Just a little bit of ortho because we use ortho for everything, vitamin U. We usually started on our kids that once we already have a diagnosis, let's say like I'm not going to do it on a biliary atresia before they have a Kasai, so usually after, but our PFIX, our Alagils, almost all of them are on ursodiol, my giant cell hepatitis, and usually I keep it until the bilirubin comes under 1 to 2. So they can be on ursodiol for a long time. It helps with itching. All these kids, when they have bilirubin deposited and other diseases that have itchy problems, we have tried medications like antihistamines, rifampin, naltrexone. So I mentioned them because this is part of the medications that we typically use in our chronic cholestatic kids. Liver transplant, this is why we are here, is an accepted therapy for many of these conditions, and actually all of our kids, despite great management, they still might have problems and need a liver transplant. So early referral is key. We love seeing these kids. So again, if you're worried about cholestasis, just let us know. Biliary atresia, still most common cause for kids needing liver transplant, 50%, but you have other genetic cholestatic diseases. You have metabolic diseases, MSUD, for example, not necessarily cholestatic, but metabolic diseases are still there as needing transplant. So just to summarize, because I know I only have 3 minutes, you need to have a high degree of suspicion in order to identify these cholestatic kids. You're going to see a lot of jaundice kids. 80% of the kids are going to be jaundice, but some of them are going to truly be cholestatic, and you need to identify them. So if you have a baby and your 2-week-old well child check that's cholestatic, get a fractionated bilirubin. If that direct or conjugated is high, we need to know. We need to see that baby. Early referral is so important. And then in the meantime, you want to feed them. You have a persistently cholestatic baby, just do some NCT, progesterone alimentum, fat soluble vitamin replacement, and that helps a lot. Any questions? I'm going to try to answer as much as, I don't know, I didn't see anything specific coming, but.
Thank you so much. That was really, really informative and great. And I really like your style. It's hard to do this without any audience in the room. So thanks so much. We have a couple questions. So from Shaquita Bell, if you have gotten at least one indirect and a direct bili level in an infant or neonate, and there's no conjugated bili, can you rule out cholestasis?
If that conjugated bilirubin is 0 or zero 0.1, really, really low, odds are that this is not going to transition into a cholestatic disease. Again, biliary atresia is ones that even in the newborn period, right in the 24 hours of life, they do see a direct hyperbilirubinemia. Now, I'm not saying that it cannot progress. Very, very unlikely. So if you have a kid, 2-week-old, is jaundice, conjugated bilirubin is 0, still follow them at the 4 weeks of life. You can always do that 1-month-old whale child check and see what they're doing. Let's say that this is an exclusively breastfed kid, they're growing, maybe do a trial of formula and see what happens. But a kid that's still cholestatic at the 4 weeks of life, I get iffy about them, and I would probably repeat a fractionated bilirubin. I don't think I will ever tell you not repeat labs on an infant that's still cholestatic at 1 month of age.
Thank you. And then a lot of shout outs for you and from pulmonary. And then from Dr. Quinn, any comments on microbiome in kids who have biliary atresia?
Yeah, so microbiome is, it's everywhere, right? So a lot of these new studies on biliary atresia, they are thinking about the relationship of like infections and kind of like that gut interaction, and why does this biliary atresia form? They still haven't been able to prove a mechanistic relationship, but we do know that, the gut is so important, especially all these cholestatic babies. They have abnormal microbiome because you're not getting the bilirubin into their gut. So their microbiome and how that bacteria interacts with the rest of the body is very, very different. So we do see some interactions, but again, it hasn't been able to be proven causative. Another thing that supports the idea of an infectious kind of etiology, for example, is that we almost always see these babies come in threes. Like if I see one BA, I'm like, oh my God, there's gonna be 2 more coming, and there's like a time kind of like peak seasonal peak in some of the kids. So once we have one, I always tell the nurses keep an eye because there's gonna be a new referral coming for another cholestatic baby.
So thank you everyone for being here. Thank you especially Dr. Blondette for being here. And if you're still listening and you get an evaluation form in your email after this, please make sure to fill it out, and we'll see you all next week. Thanks so much, everybody. Have a good day.